that is wrapped up the formal part of our discussion today. We do have a few questions that I can go to. The first one is this tool available only for hospitals, and or could private practices have it implemented? Now, this is just for hospitals right now. It would be hopeful in the future that we could have a application that can be used in the outpatient setting for sub-Q insulin, but that currently this is just used in the hospital. However, with the sub-Q application, when the patient is discharged, we do give a outpatient plan based on how the patient responded to the insulin therapy in the hospital. So there is that start. Then the next question is, has EndoTool been trialed or used in the operating room? I know we have a number of clients that do use EndoTool in the operating room. For our panelists, or any of your hospitals using it in the operating room?
Plan to, but not currently. And Paul, when I was at Eastern Virginia Medical School, we used it in the operating room there, or an insulin dosing application there.
We use it in the operating
Oh, okay, excellent.
Yeah, we do too.
Okay. And Dorothy, are you the outlier?
Well, I used it in L&D for C-section in
Okay.
fellowship. And we are talking about potentially using it here for our surgery. We have it
Yeah,
everywhere
well-
else. Just waiting on you.
Apparently, the benefit is they come out of the OR in better control, and they're on the same system when they're in the ICU being managed in the postoperative state. And it's a big difference from what I remember our anesthesiologists describing their management of glucose in the operating room. Another question we have is that now that you're using EndoTool, what is your confidence level that you'll be successful with the new CMS reporting requirements?
I would say right now we don't know the actual metric they're going to use, but looking at my own data, I would anticipate that if we didn't have EndoTool, if you remember that slide, in 3 months we had 55 episodes of severe hypoglycemia, and I didn't actually sort that out whether that would have many of that would have met CMS criteria, but are they going to penalize at a 1% rate, a 2% rate? I don't think anybody knows that answer, but
real quick to that, before we used to just compare ourselves to ourselves. We would look at our data last year compared to our data this year, and if it wasn't any worse, we were happy. But about 2 years ago, we started participating with the Society of Hospital Medicine, CQM, on glycemic control, and we learned that for IV, we were kind of in the middle of the pack, and for sub-Q, we were at the bottom of the pile. So we finally learned that other places were doing better than we were. Now, a lot of these 5 metrics, they tend to have a tight range of best to worst. Sometimes one CAUTI throws you from top 10 percentile down into the middle of the pack again. But still, we didn't really know where we stood compared to at least a cohort, and this cohort is 86 hospitals. So I think back to what Joe was saying, probably there will be, when right now we're all starting this data collection phase and we're all seeing how we're doing. And I think once that's spread and that deviation is defined, we'll see what CMS wants to do with it. But I think, again, if you don't compare yourselves to the rest of your peers, then you don't really know where you stand. And that was a big eye opener for us.
Yep. Great. Thank you. I have a question specifically for Dr. Kodzwa. How does your institution handle patient to nurse ratios with frequent point of care testing in non-critical care areas with IV insulin use?
I think when it comes to a lot of other facilities, as I mentioned, we do have some staffing stuff. So we usually have 3. So a nurse will usually carry anywhere from 3-ish to 4, maybe, but they try to keep it at 3 patients on EndoTool to 1 nurse. So it's usually about 3 to 1. That's
Okay.
how they kind of handle that. Now in the ICU, because they have more nurses, it's usually anywhere from a 1-to-1 or a 2-to-1. So in the ICU and the higher step care areas, they have less patients that have EndoTool.
And then our final question, I believe, is which is pretty similar to what we've been discussing all along. What other algorithms, protocols have you used, and how does EndoTool compare to them?
Well, when I was in Norfolk, we had Glucomander. I would say for that length of stay data looked similar between these two tools, but I think the hypoglycemia rates are different. And I think one distinguishing thing with EndoTool and the big we, just presented some of the data about using EndoTool in renal failure patients and not having a lot of hypoglycemia. It looks at how much insulin is estimated still to be in the patient, the estimated residual insulin calculation. And I think that's a discriminator between really all the other insulin dosing applications that I'm aware of. And I think that helps get you a better hypoglycemia rate in terms of being lower because taking that into account.
Yeah, that feature with EndoTool is key in patients that have renal insufficiency. We've actually shown our own internal data analysis that patients have a GFR less than 20 have no higher incidence of hypoglycemia than those that have a GFR greater than 60. So it is a real, it allows patients to be with renal insufficiency to be treated without development of hypoglycemia. And I think that wraps things up for our questions today. And I just want to thank our panelists for their participation today. I think it's been a really worthwhile discussion. And just want to thank you again for your participation. And those that are on the webinar, if they have questions or would like to discuss things further, please don't hesitate to reach out to me. And my email, I believe, is on this final slide. And please be on the lookout for future webinars. So thank you, everyone, and enjoy the rest of your day.